Now, depending on how complex the case is, resourcing an EMDR treatment of chronic pain can involve the usual kind of resources, such as a calm, safe place or a nurturing figure, but it's also going to probably involve creating some sort of antidote imagery or affect associations to help the client manage pain. And these can come from imagined abilities, positive memories, sensitive changes following bilateral stimulation. And resourcing can involve creating emergency self-soothing strategies. So we're going to kind of move into that phase of treatment now. And just making the point that resourcing in the treatment of chronic pain, it's involves a bit more than it just does in the processing of trauma, where where resourcing is primarily about evoking, an adult perspective. In the treatment of chronic pain, where sort of residual pain is quite likely, it is going to involve the additional creation of resources, imagery, and so on, that the client can use to help manage ongoing pain. So this is just a summary example of resourcing in the treatment of a woman who suffers from low back pain. This is actually the case I mentioned earlier, where in terms of the case conceptualization, she had been her pain had been dismissed, and she had doubted the reality of her pain and was forcing herself to engage in physical activities that exacerbated her pain, in the belief that her pain wasn't real. So her diagnosis was osteoporosis, and she'd had a fractured vertebrae which was undiagnosed for 2 years. She also suffered from hypothyroid, shingles, and had some medical mishaps while she was in the hospital. Abusive background, angry, drunk father. She's got a strong protector part who puts a lot of pressure on her to fix herself, which is great, and she's working and actually maintaining quite a normal life, but really carrying a lot of tension in her body, which is maintaining her pain. She's very motivated to do anything to help herself, quite psychologically aware, medium kind of levels of hypnotizability. So, and with resourcing, I simply this is kind of what I call a direct resourcing strategy, and I just ask her to focus on your pain and think of something that could make it feel better. Now, I'm doing this after I've been treating her for a while, and she's stable, and she's got some improved ability to manage her pain, and I'm trying to dig a little bit deeper and help her to create some resources for herself. So in response to that question, she says, my body can regenerate itself. That just came from her spontaneously. That she could trust her body to do that without her having to try so hard. She then said that she volunteered, that kind of spontaneously, that her pain can just become a memory. So this is all during continuous audio BLS. And she says a memory that she doesn't need anymore. Then she volunteers she can remember the good things before pain and the good things that pain has brought her. Then she notices a feeling of relaxed strength, something sort of within herself, rather than feeling that she has to be stronger than the pain. And so I'm just doing continuous audio bilateral stimulation and just letting whatever comes. So between each of these statements is, at some point I'm asking what's happening now, what are you noticing now? She then reports that she feels like she's going into a safe tunnel of calm relaxation that feels somehow protective of her body, and associated with that a feeling of things being different. Then she describes feeling relaxed and calm, and feelings of love and forgiveness and warmth, and that her pain sensations feel further away. This all happens within probably 4 or 5 minutes. Then I simply instruct her to remember what she's learned and go back to that experience and practice reliving it and re-experiencing it. So that's direct resourcing. And by the way, when I followed up with her, how she went after that session, her next session, she reported that she'd found the tunnel very helpful, that it gave her the safety, a feeling of safety that made her feel ready to start addressing other trauma that were associated with the onset of her pain, including the invalidation that she'd experienced, and that she was feeling more empowered to make choices that were right for her, and to contemplate the possibility of a life without pain. Associated with that, she was feeling more able to live with less pressure. See how we're sort of starting to move towards integration here? Between her parts, the part that wants to fix her and the part that needs to live in her body in the here and now. And that could happen without her having to try so hard. That there's more of a belief in her body. And she said literally, maybe my body can switch it off. And she also described that she'd had a feeling of being tied in knots, and that felt that she just felt looser and more relaxed in her body. For me, one of the most important resources, if you like, is just the ability to change states and to notice that. So I've kind of been talking about this indirectly, but I think it's worth stating explicitly, that when we talked about dissociation earlier on and harm avoidance, and how clients are avoiding engaging in sensory experience as a way of protecting themselves from feeling overwhelmed. Then this ability to engage in the world in a sensory way and to respond to sensory stimulation, including, of course, bilateral stimulation, and absorb that and notice the effects on that on their body, actually represents a kind of resource. So that's just something I want to say there. And it's the opposite of course, of dissociation, harm avoidance, shutdown, and so on. That ability to move between vagal states. And of course, to integrate those sensory changes into positive beliefs about them and their ability to cope with their pain or trauma. I think Spinoza really got it 400 years ago when he said, the more capable the body is of being affected in many ways, the more capable of thinking is the mind. And it's your job and my job to help our clients do that thinking and connect that thinking with what's happening in their body, and to integrate those sensory changes into new ways of thinking and feeling and living with themselves and in their bodies. Another source of resourcing or resources is the sensory changes that the client reports following bilateral stimulation, and using those sensations as the basis for creating an antidote imagery. So remember, in the targeting phase, you ask the clients where they feel the pain in their body and to describe in terms of a size, shape, and color. Well, now we're doing that with the feelings of relief that they report following bilateral stimulation. So what's there now where the pain was before? Again, just want to say here too that so your job doesn't end when the client says their pain's reduced. You actually want to milk those changes. So what's there now where the pain was before? And the client says, oh, well, it feels softer, more relaxed, more normal, more okay, just more healthy or more well, more how things should be. So, and then you get the client to describe those feelings in terms of a size, shape, color. And then get the client to form an image based on either what their descriptors remind them of or feels like, what image goes with that description, a word that best summarizes that feeling, and then install that with bilateral stimulation and or hypnotically, preferably a combination of both. So that's a different step and an additional step to just installing a positive cognition once the client reports feeling relief. And you're also, in addition to creating that resource, at the end of the day, you would encourage the client or advise them to practice thinking of that word and the image that goes with that and those feelings, and pairing that perhaps with bilateral stimulation and just making that part of their daily coping routine. So however you word it, it's about creating awareness of positive sensory changes and associations between those sensations and imagery or memory that you can use as the basis for creating a resource, a sensory-based resource, which, because it's come out of the client's present experience and it's associated with what they feel in their body, for my money, is much stronger and more effective than an imaginal one. That's perhaps based on something that the client's thought up or even perhaps has been suggested to them, but is not really based on something they've actually experienced and felt. And here's a list of comfort words. It's again, probably this is another one you should print out and have on your wall somewhere, because it's really important to have the language for comfort. As much as people can describe their pain, they also need to be able to describe how they feel when the pain's gone, what being healthy and well and pain-free feels like. So, cool versus hot, dull versus sharp, soft versus hard, and so on. And just repeating or covering again some of those tips for tracking and facilitating changes. Of course, the instruction to just notice, not trusting the client's ability to always pick up on everything that's happening. In addition to the other tips that I gave, sometimes it's not just about the pain, but what else is going on in their body, and so sometimes the client might report that the pain doesn't feel any different. But then if you direct their attention to the rest of their body, how does the rest of you feel? They may often report that they feel more relaxed, and that can also change how they experience their pain and are affected by it, because the more relaxed a person feels, the less distressed and the less intensely they're going to experience their pain. Again, looking for micro changes, titrating that awareness or that focusing on the body, knowing the possibilities, and not being afraid to actively suggest possibilities. So if a client, reports not noticing much, you can gently suggest maybe they notice feelings of lightness or heaviness or relaxation, or just that their breathing has changed. It's okay to do that, of course, in a kind of permissive gentle, non-pressured way. So now we're going to have a look at a clip just showing what that process looks like of creating sensory-based imagery, and again in a very simple case of present pain. Okay, so I'm just going to talk a bit about resourcing for helping clients with chronic pain, and I'm really talking specifically about creating resources for helping them to manage pain and its effects. So it's assumed that you already know something about resourcing from your basic EMDR training and whatever other training or experience you may have. Particularly, I want to talk about the use of imagery and the various ways that can be done. Of course, so it could be just things like a healing light or water or any kind of imagery-based resources. It could be an antidote that you create in relation to the client's description of their pain, and imagine the opposite of that. Could be something like a pain container, which is kind of another version of a feelings container. You can use memories. You can use just the distancing that clients experience sometimes following EMDR, and something called pendulation, which I'll describe shortly. So antidote imagery really just involves creating something out of the client's experience that reverses or neutralizes their pain. So you get the client to describe their pain in terms of its size, shape, and color, linking that to an image, and then simply ask them to think of the opposite of that, something that could take the pain away or make it feel better. And at that point, you're kind of inviting the client to do that. You're really accessing the unconscious mind. It's if they think about it too analytically and kind of left brain, they might come up with something that seems on the face of it brilliant, but it's probably not as effective as those more imaginative right hemisphere, left field kind of ideas. Then you simply pair it with bilateral stimulation and or reinforce it hypnotically. And I attribute this to Bruce Eimer, that his original writings about EMDR and the treatment of chronic pain back in the 90s. It's probably older than that, but that's my earliest memory of encountering this strategy. And the pain container really just is similar to a feelings container. It involves just getting the client to imagine putting their pain inside a container, closing the lid, locking it up, and moving it someplace further away from them so that it's less distressing and less bothersome. The other one that I mentioned in the kind of introductory slide was pendulation. This comes from Peter Levine. And pendulation involves getting the client to focus on their pain and noticing what, the size, shape, and color, what that feels like, getting a real sense of that, perhaps an image that goes with that, and then just putting that aside for a moment and directing their attention to a part of their body where they feel no pain or discomfort, where everything feels fine or okay. Could be their earlobe, could be one of their toes, doesn't matter. And just noticing how different that feels, how relaxed and natural and healthy and soft and okay everything feels, just getting a sense of that. And then once you've got a clear sense of that, bringing their attention back to the area of discomfort, but imagining that as they do that, they're bringing back a little bit of a sense of that comfort that they notice in that part of their body that feels okay, and then just concentrating on the area where the pain is, again noticing the size, shape, color, just getting a sense of that, and perhaps not noticing it quite as long this time. And then once they've noticed that, putting that aside, to redirecting their attention back to the area of comfort and just noticing the feelings of comfort and naturalness and okay and relief and warmth and softness and whatever it is that they notice there, and spending a little bit longer on that area than you did on the area of pain. And then when they've got a clear, strong sense of that, again bringing their attention back to focus on the area of pain, and again imagining that as they're doing that, they're bringing across a little bit of that awareness of that comfort and relief, and just noticing the area of discomfort as they did before. And again, not spending as much time on that as you do on getting them to focus on the area of comfort and relief. Once they've done that, put that aside, redirect your attention back to the area of comfort and okayness, and just noticing how okay and normal and soft and warm and okay that area feels. Just getting a really strong sense of that, just noticing that, just paying attention to that with all your mind, really getting a strong sense of just how okay and pain-free that area feels. Then when they've got that, redirecting their attention back to the area of pain and discomfort. Now you do this, half a dozen times, and then instruct the client to take a break and notice what the area of pain and discomfort feels like now. And in a lot of cases, they'll report that it's reduced, because of course you're contaminating their memory, their experience of the area of pain and discomfort with their awarenesses of the area of comfort and relief. So that's pendulation. It really comes from Peter Levine, and an exercise that he does with trauma. I've just adapted it for work with pain. We'll be talking in more detail about imagery in day 2 when we get into hypnosis. So don't worry, there's more to come. This is another exercise that I use for clients who are in the grip of a pain flare-up and who are feeling overwhelmed by their pain and need something short and sharp to help generate some feelings of relief. So basically it consists of instructing the client to go inside and notice their feelings of discomfort and what it feels like and where they feel it. And then thinking about what those feelings need, and making a short statement to themselves that addresses that need. For example, pain gone, or for pain, or safe to sleep for insomnia. So very short and usually directed exactly at whatever distressing symptom it is that the client's experiencing. It's got to be short and non-analytical. And then you just instruct the client to repeat that mantra silently or out loud, and pair that with bilateral stimulation. If you've got the right words, and you'll know that because it'll resonate, the client should fairly shortly start feeling some sort of relief or reduction in their anxiety or pain or fear about not being able to go to sleep. If they're not, then they're probably not using the right words, and you need to sort of play around a little bit until they get the right wording. So really the emergency self-soother just consists of helping the client to generate a self-soothing resource for them that really addresses their pain and discomfort. So I'm going to show you a little example of what that looks like in practice. So what you're about to see is an online session. That's why you can see the client and myself in the top right of the screen, with a 34-year-old ex-policeman who has chronic pain and who's just had a pain, or in the grip of a pain flare-up. He's had pain for quite a few years, had a lot of injuries in the course of his work as a policeman, as well as all sorts of traumas, including losing his best friend in a motorcycle accident. So you'll see in this exercise that I'm using bilateral stimulation from my Calm and Confident app, and that is what you're looking at with that visual, that graphic there. And we're using the emergency self soothing exercise to help him find a mantra that'll help him to feel better. Initially, he starts off with saying he doesn't know why he's not improving. And then it changes to finding calm and turning down the volume. And finding calm is really the mantra that ends up working best with him. We pair that with the bilateral stimulation, and he gets as kind of a stream of associations that eventually, culminate in him experiencing some real relief. So I want to talk now about another case, a more complex case, far more typical of my work. So I demonstrated for you how EMDR is effective with simple trauma and pain. But when you're getting more complex presentations, it needs to be integrated with adjunctive strategies such as hypnosis, ego state work, somatic psychology, and so on. So these are clients who've had multiple trauma, attachment problems, complex medical presentations. They often present as exhausted or dorsal vagus shut down, or some sort of combination of hyper and hypo arousal. Usually there's quite a bit of fatigue, and they're not nearly as resourced or as stable as those clients who you can just start off with EMDR and work through the way that the way I described in that case of whiplash, and you saw in the phantom limb pain example. So just to illustrate how therapy looks a little bit different in these cases, I'm going to share with you the case of a woman I treated a couple of years ago. She was a 39-year-old nurse, wife, and mother. She's been in pain for 8 years, or had been when she came to see me initially. She'd had 2 failed surgeries. She also had complications arising from a pelvic mesh procedure. She also complained of headaches. There's third-party involvement, and all the problems that go with that, pressures to get back to work, questioning her symptoms, and controlling her access to treatment, etc., etc. She's on a ton of medication for pain, for depression, mood stabilizers, insomnia, etc. Her pain has had a devastating effect on her ability to function and live a normal life. She's lost her job. The couple have had to sell their house because of financial strain, and of course, it's affected her relationship with her spouse, etc., etc. She's also suffering from a major depressive disorder and PTSD associated with the accident that triggered the pain, and to some degree the pelvic mesh situation. And there is developmental trauma in the form of emotional neglect in childhood. So this is that timeline that I showed you earlier of just representing more complex cases. So you can see that her pain didn't really start with the injury that she had suffered. It probably started in childhood, when she was emotionally neglected, and then there was this sort of cumulative life stresses culminating in the work injury and the development of chronic pain. But by that stage in her life, she was really already living in a body that had endured an awful amount of stress, and was very tired and vulnerable to the development of chronic pain, then exacerbated by failed treatments and third-party involvement and so on. It's kind of almost a CPTSD presentation that you're looking at. Now, in terms of personality, she's she's quite stable. She's I suppose a sort of stoic personality, very, very enduring, self-sacrificing. You'd say she was emotionally inhibited. So she's someone who kind of keeps her feelings to herself. She's medium hypnotizable, which is good, in the sense that she's open to really new possibilities, EMDR, imagery, hypnosis. She's got a disconnection rejection schema, and particularly since the injury, but probably always masked behind a sort of strong coping persona. I think a deep sense of uncertainty about her autonomy and ability to survive in life. And all this was well under control until she got hurt and developed chronic pain and just couldn't continue to function anymore. So my treatment of her consisted of a mix of EMDR, hypnosis, ego state work, and kind of somatic focus. And I certainly didn't start with EMDR, but when she'd got enough control over her pain and emotional distress, with the assistance of hypnosis and resourcing, these are the EMDR targets that we worked on. So number one, her pain, negative cognition, there's something wrong with me, and the positive cognition, which was obtained post EMDR, was I'm okay. We also processed some trauma around her injury and the pelvic mesh situation. The negative cognition, I'm unsafe. Positive cognition, I survived. And the effects of pain was the third EMDR target. Negative cognition, I can't provide. Positive cognition, I'm enough. In addition to EMDR, I did pendulation with her for helping, as a pain management strategy primarily. Some hypnosis using imagery and suggestions for managing her insomnia and her pain. I used something which I developed for neuropathic pain, a script that I'll be introducing you to in the hypnosis section of the workshop. We did some ego state work for a part that's called the Southport Girl, which is her sort of tough survivor part. Southport being a region in the UK where she'd grown up. Some psychoeducation around self-care, linking that, of course, with the ego state work, and some kind of sensory strategies for helping her manage ongoing pain, such as hot and cold stimulation, movement therapies, and so on. All blended in with EMDR. And so I'm just going to share with you some highlights from her treatment. It was about 13 sessions over a year or so, and it was not a straightforward treatment. There was a lot of ups and downs and backwards and forwards. So from her sixth session, she was dealing with the guilt that she felt about the effects of her pain, and which really linked to a long-standing sense of unworthiness and not being good enough, and associated with that, sort of isolating herself from in relationships and not letting people get close. So we targeted some of that with EMDR, and that led to awareness of more guilt associated with not providing, and anger at just a loss of sense of identity, feelings of being invisible, and a need to be wanted. Then I actually ceased EMDR and did some parts work around her child and adult selves, helping bring in the adult into awareness of the child and helping her to witness the child and inviting the adult forward as a resourced part and accepting the child, and that led to her statement that I am enough. So her treatment progressed smoothly for the next 3 or so sessions, but then at the 10th session, which was about 3 months later, she had a big pain flare up and really seemed to slide backwards. She was increasing her need for painkillers and feeling really stuck. She was saying, look, I've had these operations, I'm doing the exercise, I've had EMDR, I'm doing everything right. This is not working. I can't hide it anymore. That I'm not in control, that this pain is winning. She described feeling bone tired and having dark thoughts, and that she just felt like she'd had enough, and then wondering whether she'd been kidding herself. She was saying that work was just killing her in terms of its effects on her pain and how it was exacerbating her pain. So, obviously I'm not in a good place, and a little bit stressful for me as a therapist, thinking, what do I do now? She'd also, she was saying that the treatment wasn't working for her, and she was feeling desperate, and like there was, what else could she do? And remembering just how life changed in a split second of this accident, and being fine without any payout. So actually, what I in my desperation, what I decided to do was just to do the flash technique. Phil Manfield's brilliant self-soothing strategies, if that's what it is, to see if we could just help her reconnect with the progress that she'd made and neutralize the distress that she was feeling about her current pain flare-up. And it worked brilliantly, and so I just instructed her to tap on her knees bilaterally, notice the distress she was feeling, thinking of something that could make her feel where she could feel better or calmer, and flashing on that. And after a few minutes, she reported feeling lighter, and that she could let go of all the distress that she was feeling, and somehow she was able to reconnect with the progress that she'd been making up to that point. And basically her therapy got back on the rails after that. By her 15th and final session, she was really in a stable, consolidated, good place. She had a new job, which she was enjoying and coping with well. The family was buying a new townhouse to live in. Her back pain was still present, but she felt that it was much more manageable, and that she felt in control over it. And when pain comes, she would just say, no, let's change the frame. So the pain was having a much less important role in her life, and she, quote unquote, described feeling like herself and really knowing who she was and confident and comfortable with who she was. She was also sleeping a lot better. So I'm going to show you a interview I did with her shortly after this, just describing her progress in treatment. And just for your interest, following this interview, I spoke with her a few months later, and she was actually pain-free then and off all pain meds. But this interview was conducted a little bit before that. So just before I run that video, as you can see from the subtitle there, she's really in a different place in her life and living happily and joyfully. Just one other comment. The title of the video is EMDR Treatment of Secondary Pain. So that this reflects the evolving terminology for pain management. So primary pain is what they now refer to as pain that where that is the primary problem and it's not associated with a medical diagnosis. Secondary pain is pain that is associated with medical diagnosis. So that's what the terminology that's being adopted by the ASP, or sorry, the IASP, is these days.
So if I can, Tracy, can you just tell us a little bit about your story? What happened and what was, what you were looking for when you came to see me?
Yeah, sure. Well, it all started 1st of March 2011. I went to work like any normal day, and a patient grabbed me. I'm a registered nurse working in mental health. Patient grabbed me and I could feel my back just go pop, pop, pop. And I thought, oh, it's probably muscular. And so I sort of worked through it, and it just got worse and worse. And then one day I just couldn't stand up at work and the pain was incredible. That's when I started on workers' comp and did the whole return to work program. Pain management was part of that. I was put on a ridiculous amount of medication immediately, and found that I couldn't get off that because of the addictive qualities, but I did. I was determined, and I got off them once, and then did the whole return to work program. That failed, so I was let go from that job, and I then sourced my own job and declared my back injury, went back to work, was able to go back full time. And then one day, again, it all just fell apart. So I went back on those meds, and I had 17 months off with 2 operations. I had both my right and my left sacroiliac joint fused, and the pain was still there. I had been told that my L4, L5 and S1 and my right sacroiliac joint was injured in the when the patient grabbed me, and the pain was just still there despite the operations, despite the medication. So a good friend of mine gave me your details, and to be honest, in sheer desperation, I contacted you, and here I am today smiling because of it. So I'm still on the medication, but at a very reduced dose. I'm working with my GP to get off that. Like, I'm only now taking the oxycodone slow release 10 milligrams twice a day, and I'm taking endone PRN, which 5 milligrams was up to 6, 7, 8 tablets a day. I'm now down to 1 after lunch and 1 before going to bed. The pain is still there. I've just moved house, so the pain levels have gone up, but I haven't needed to increase the medication because at the end of the night I put my headphones on, and the EMDR just does its thing, and it acts like a circuit breaker for me. And I don't need anything extra now because of that. So sometimes I'll put a heat back on if I can't do the EMDR, but that's my story. So I'm 10 years into this injury now, and I've got a different outlook on life, because even 2 years ago I didn't think I had a future. And if I did think about my future, I thought it was going to be in a wheelchair. So
wow. Well, thanks, Tracy. That's amazing, and thrilled to hear of your success and changes. I'm glad that you found the EMDR helpful, and you're still using the bilateral stimulation to manage your pain and stress. I know that you went through quite a personal transformation, and that you look at things very differently, and you deal with your feelings and your own needs very differently now. Would you be able to just say a couple of words about that?
I actually acknowledge that I have needs, and it's okay to have needs, and that those needs need to be met. I'm not afraid of that anymore, and I'm not afraid to say no, and if it doesn't suit me, if I don't like something, not only were you able to help me with pain, but you were also able to help me with my self-worth. So, and that was all part of the process. I didn't set out to, I didn't think I had a problem with that. And I think you actually told me, you know, no, we're not done. You know, I was sabotaging it because of the lack of self-worth, which the injury had made me, yeah, it ramped up during the injury, yeah, because I'd been told, you know, that nobody can help me. This, I was even told, you know, it's in my head at one stage, and that I was a malingerer. And, you know, so it's, yeah, that's why the future was bleak, because, you know, I just thought nobody cared. And so if they didn't care, why should I? So.
Oh, thanks for that, Tracy. I'm so proud of the growth that you've achieved and the change. I know you're a stronger, happier person for that.
Oh, definitely.
So, yeah. Just one last question: what is a Southport girl, Tracy?
The Southport girl is a tenacious little lass. She's very stubborn, but to her detriment. You know, yeah. But I was able to explore that and to feed that little girl in the process. And now the Southport girl is probably a Southport woman, but a very bolshy woman that knows what she wants and is happy to go out and get it.
Oh, that's fantastic. I'm really glad that the girl and the woman are working together so much more closely now in the same body.
Yeah, we're not fighting each other. No, we're not. And she's not sabotaging, and for whatever reason. And yeah, we're in tune. We're in sync. So yeah. And it works. Yeah, it works. I can't thank you enough for what you've done. Given me my life back, and not just back, but better. You know, it's quality to it now.
Just a pleasure and an honor, Tracy, really. And I'm glad to hear you've got your husband rubbing your back. That's good.
Yes, and he volunteers every night because I'm working full time again. So
yeah, that's amazing.
I know, and I've just moved house, and it's all still going. Yeah, and yeah, he's more than happy. Yeah, so that's good.
You're working as a team.
Yeah, exactly, and we have to. And that's well, that has changed as well, my relationship, because I think I brought that up as an issue with you, way back when. And that's changed. We're both on the same page. We both have the same goals. And we're a team. And it's good. It feels good.
Oh, two is better than one, Tracy.
Oh, definitely. Yeah.
I think so. In a way, it's like the Southport girl and the woman are a team, and then you're more able to be a team with your husband as well. Okay.
Yeah. It all just sort of slots into space, into place. It was, I think it was like a subconscious thing. So, but yeah, I'm loving my life.
Oh, thrilled, Tracy. Thank you so much for your time tonight.
So again, just to summarize, why did I need to use adjunctive strategies with this patient? Why didn't I just do EMDR? Because she's essentially suffering from CPTSD. When she initially presents, she's exhausted, her pain's not adequately managed, she's overwhelmed by the effects of stress and trauma and the effects of her pain. Her general health and well-being is poor. She's got a lot of safety issues around, her pain and injuries and disability. She has conflicted ego states between the part of her that wants to be in control and manage everything and the part that feels vulnerable and overwhelmed. And she's really got virtually no emotional support. Her partner is just not there emotionally. So in terms of the wheel of therapy, the therapeutic relationship was very important, as much as anything else that I did, in helping her to feel validated and less alone, and providing a foundation or a template, if you like, for her to reconnect with herself and her own ego states and be there for herself and her life. All right, so we've covered the desensitization stage, installation, and we're now ready to look at the kind of end phases of EMDR, the closure and reintegration, and that's really mainly about helping the client maintain that awareness and integrating the positive changes that they've experienced during EMDR and or whatever else other therapeutic modalities you've been using, developing a sort of post-pain sense of self. So that could be, that's usually, acknowledging that there are losses and changes and things that the person can't do that they used to be able to do, but still being able to feel good about themselves and, that life can be meaningful and worthwhile and productive. And often the the final stages of EMDR also involve creating future templates and developing and maintaining those for managing residual pain. So in many cases, the pain is not completely resolved, and clients need strategies for managing ongoing pain and discomfort. So in a kind of neutral, curious way, I'm constantly revisiting the client's lived experience of their body and their bodily functioning and their basically their pain and discomfort, and just looking for any little differences in their experience of their pain and its effects on their lives, always in a very permissive, curious, non-pressured or suggestive kind of way. So, have you noticed any differences in your pain levels or how you experience your pain in the past week or however long since I last talked to you? And really getting the client just to review their life experience, looking for any kind of little differences or changes in their experience of their pain. And this is something that I actually learned many years ago in narrative therapy with Michael White. And one of the things they teach you in narrative therapy is to be curious about what they call unique outcomes, and that is sort of experiences that are exceptional or different in terms of how the client usually experiences themselves and their problem. And it's called unique outcomes because when clients live with a problem for a long time, they tend to develop a narrative around that does, that excludes or doesn't pay attention to exceptions, times when their pain didn't bother them or when they felt in control of the problem. And this questioning about clients' experience of themselves and their problem in this kind of open, curious way invites them to be more aware of those exceptional moments that create an opportunity to create a different narrative rather than the problem-soaked narrative, and then building on that. So making it what they call newsworthy in narrative therapy. So when the client describes having a few good days in a row, for example, when they haven't done that for a long time, or they've done something, an activity that they couldn't do before and it didn't hurt as bad as it used to, just respond, without getting, I suppose, in a kind of distancing, curious, detached way, just observing, well, that sounds new. When was the last time you were able to do that? And I wonder what that means. So you're not going, oh, that's fantastic, well done. You're not cutting the client's lunch for them, but by being curious in a detached sort of way, you're creating a space where the client can create their own new associations and narrative. It's quite subtle, but it's quite powerful. It's kind of really fits with that whole staying out of the way approach in EMDR. So again, a future template is something you'd be familiar with from your basic EMDR training. In terms of pain, I do things a little bit differently. So I'm going to describe my process. Then I'm going to show you a little clip of what that looks like in practice. So, now by the time you're doing this, you've done a lot of work with the client. They're by now they're used to using their imagination and connecting and finding inner resources. So take a moment to go inward and be with yourself. Imagine yourself having what you need to manage your pain. Just being able to find what you need to feel better. Some of you, of course, will recognize that there's quite a bit of a hypnotic element to this. Inviting that in, bringing in that healing light, color, energy, however you see it. Breathing it in, filling yourself up with it. That's it. With every breath, more and more, that's it. Bringing more and more of that healing energy into your body with every breath you take, just letting it happen. Just noticing how it makes you think and feel about yourself. Seeing yourself managing your pain more confidently. That's it. That's it. Now think of that. Think of that, and then pairing it with body stimulation or just installing it hypnotically. So just noticing how you feel in your body now. And just filling yourself up with those feelings of calmness and relief. Imagine those feelings of calmness and relief, filling every cell of your body, just letting those feelings of calmness and relief spread throughout your body more and more with every breath you take. That's right. And so on and so on. So the clip I'm about to show you shows a future template and kind of a client integrating her parts, following ego state work, somatic focus, and EMDR, and how the future template can emerge out of parts work. How she comes to see herself coping and practicing, employing the resources that she's developed. So this client, as the history is that she fractured her coccyx 16 years prior to commencing treatment with myself, and as a result of that, she can't sit or walk for more than 20 minutes, half an hour. She can't drive her car for more than 20 minutes away from her home. Treatment-wise, there were a lot of delays in treatment and mismanagement. A chiropractor diagnosed a fracture in her coccyx and a dislocation above the fracture in 2011, some 5 years after her pain had commenced. So it had been missed in x-rays. She thinks that the dislocation from the C-section, or came from a C-section she had during a pregnancy, because that's when her pain started. At that time, she had to rely on a walking stick to walk. There were some other complications with the pregnancy. She was hospitalized with mastitis. Again, many years since she's been able to sit or walk normally. She's had a neurostimulator surgically implanted, ketamine infusions, seen numerous physiotherapists, occupational therapists, pain specialists, and so on and so on. She's quite interested in alternative methods and takes a lot of responsibility for finding out different treatment approaches. She understands about neuroplasticity and how brain activity is altered by chronic pain, and what sort of things you can do to change that. She's medium hypnotizable, very spiritual person, not dissociative, although at least in a clinical sense, but she certainly has parts and ego states. Father died when she was only 19, and her mother became an alcoholic at that time. She's got quite a strong, optimistic, resilient personality. She's managed to, despite her pain and disability, she's managed to still work a couple of days a week from home. What else can I tell you? At her first session, we did some trance work, and I asked her what was stopping her from moving. and she said fear, and she sort of started shaking. And we did some somatic experiencing, getting her to notice what was going on in her body, and just, finding whatever she needs, letting whatever needs to happen, and finding what she needs, what her nervous system needs. And she started to calm down and became aware of kind of, I guess, the levels of trauma and stress that she was carrying in her body. At a second session, I did some more hypnosis and age regressing, asking her to see if there's anything that was holding her back, any conflict. And she identified a conflict between the part of her that needed control and the part that needed to accept, what she was really feeling, what was happening in her body, and what she needed to do to take care of herself. And she concluded with a realization that it was okay for her to do whatever she needed to look after herself. What else can I tell you? During the third session, and this is really when she started to identify her parts and to negotiate with them. We did some EMDR processing where she held that in her body. We did a hypnotic interweave between her different parts, and started to develop a future template. So I'll let you have a look at the video, and that's probably going to show what I do more than anything else I can say. So I think this case really demonstrates an integrated therapy process where EMDR is associated with hypnosis, ego state work, somatic focus, and why just EMDR alone wouldn't have been sufficient here to help her do the healing and integration that she needed to. Why, you can see why tracking and facilitating changes is important to help develop a momentum of change and build upon the changes that she's experiencing, and then developing resources that are based on that, integrating the work with ego state work, future templates for managing residual pain, and the whole treatment really culminating in a more integrated sense of self, mind, and body, different ego states, and that it's really, in that sense, it's about much more than symptom management. It is about healing the whole self. And then, you can see from that, in terms of the therapy wheel, that you're dealing essentially with CPTSD, with chronic pain, and therefore the treatment requires much more than just trauma processing. The therapeutic relationship was very important in creating a safe place where she felt she could explore her vulnerable feelings, resourcing to help stabilize and manage her pain and emotional distress. Yes, some trauma processing, some EMDR, and then parts work to sort of integrate the different ego states and her personality structure functioning, and that this is not, it's not it's not a linear approach. Yes, you do start with a therapeutic relationship and resourcing, but as the treatment progresses, you're moving backwards and forwards between trauma processing, parts work, resourcing. It becomes it's a very dynamic, can I say, fluid therapy process. It's really dependent on what the client's experiencing in the therapeutic moment, and what they need to contain their feelings, and sometimes going backwards rather than forwards, but ultimately the momentum is forwards. So just to summarize, we've really gone through what's different about EMDR and the treatment of chronic pain from the standpoint of the basic trauma protocol in the from the history phase, where you're obtaining a health and a pain history, including any childhood illnesses, hospitalization, and taking account of the client's current health status. In the preparation phase, naturally resourcing, but how it's more pain focused than might be the case with trauma. That the history is more complex. There's more likelihood of dissociative defenses and exhaustion in the sense of dorsal vagal shutdown, and they often, it's kind of like you're treating CPSD, that the resourcing is a major element of treatment. In the assessment phases, some of the differences there are the different targeting options, including the option of targeting present pain, substituting sensations for emotions in the TICs, building an image based on the description of the pain, different positive and negative cognitions, the option of backloading the positive cognition. Okay. Then in the desensitization phase, one of the main differences is the use of continuous audio bilateral stimulation, but also the emphasis on tracking and facilitating the effects of bilateral stimulation. And of course, also ceasing bilateral stimulation when changes plateau or when the client's feeling fatigue. The end of the desensitization, the idea of creating antidote imagery for persistent pain, you can use sensory changes following bilateral stimulation as the basis for that. Also noting that complete pain resolution is not common in those more complex cases, and a good result would be just a significant pain reduction and the client feeling less overwhelmed by their pain and more able to cope with it. That's quite a satisfactory result. Following successful treatment, integrating EMDR with ego state therapy, so that it's helping the client to resolve conflicts between different ego states and live in a more integrated state of mind and body. Maybe self-use of bilateral stimulation following EMDR for managing residual pain. In many cases, it can be quite a spiritual thing. Many of my clients report feeling much bigger as a person following successful treatment, and even able to look back on really very traumatic ordeals with health problems and pain and say that was the best thing that ever happened to them. This is not something they could have said at the start, but I've had clients say that, and I've had clients say that they feel more in control of themselves and their lives than they ever have, despite the fact that they may have persistent pain and disability. So huge personal and spiritual growth at the end of what can be a very complicated, stressful treatment journey, but outcomes that way transcend just being able to manage physical symptoms associated with pain. So that really concludes day one, and day two we'll be looking again more at these complex presentations and the role of hypnosis in the management of chronic pain and its effects on identity.